Hello, my dear. I'm Dr. Alaa Mosbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. Today, our lecture about nausea and vomiting in pregnancy according to the guidelines of Royal College of Obstetrician and Gynecologists, published February 2024. So, the objective is to know the management of nausea and vomiting in pregnancy and hyperemesis gravidarum according to the guidelines of Royal College of Obstetrician and Gynecologists 2024. What about definition of nausea and vomiting of pregnancy? It is defined as symptom of nausea and or vomiting during pregnancy when onset is period to 16 weeks of gestation and when there are no other causes. So pregnancy should be less than 60 weeks gestational age and there is no other causes of this vomiting rather than pregnancy. What is the definition of hyperemesis gravidarum? Can be diagnosed when symptoms start in early pregnancy. Nausea and or vomiting are severe enough to cause an inability to eat and drink normally and strongly limits daily activity of living. Also, signs of dehydration are contributory to diagnosis. So, there is limitation in daily activity in case of hyperemesis gravidarum, inability to eat and drink normally, signs of dehydration, nausea and vomiting severe enough to cause all of this. What about epidemiology? Nausea and vomiting constitute 90% of pregnant women and is one of the most common indications for hospital admission among the pregnant women with typical stay between 3 and 4 days. What about hyperemesis gravidarum? Hyperemesis gravidarum affect about 0.3 and 3.6% of pregnant women. What is new, and you should know, that the major mechanism of nausea and vomiting of pregnancy and hyperemesis gravidarum has recently been elucidated to be related to hypersensitivity. To what? To the vomiting hormone growth differentiation factor 15. This is a new information you should know. There is hypersensitivity to vomiting hormone called growth differentiation factor 15, GDF15. GDF15 causing loss of appetite, taste aversion, nausea, vomiting, weight loss. Genetic variant associated with expression of GDF15 in families with hyperemesis gravidarum have been identified as the greatest genetic risk factor for hyperemesis gravidarum. In the past, they considered HCG to play this role, but now it is proved because it was found in different cases of hyperemesis gravidarum, growth differentiation factor 15. Okay, what about diagnosis? An objective and validated index of nausea and vomiting, such as pregnancy unique quantification of emesis, with its abbreviation PUQE, BOC, and another tool, hyperemesis level prediction, with its abbreviation HELB. So POC and HELB, both of them are used to classify the severity of nausea and vomiting in the hyperemesis gravidarum. Clinicians should be aware of the features in history, examination, and investigation that allow nausea, vomiting, and hyperemesis to be assessed and for their severity to be monitored. This is how it looks. Debug 4 with different questions about how many times the feeling of nausea, how many times she vomit, how many times she have dry heaves, and so on. And according to the score less than 6 means mild, score between 7 and 12 is considered moderate, score equal to or more than 13 is considered severe nausea and vomiting of pregnancy. The other tool is hyperemesis level prediction or HELP score, as you see here. Okay, what else in diagnosis? You should know that ketonuria is not an indication of dehydration and shouldn't be used to assess severity. Please remember this because it was used in the past to assess severity. Nowadays, ketonuria is not an indication of dehydration and shouldn't be used to assess severity. Features in the history, examination, and investigation to aid diagnosis include, in history, previous occurrence of hyperemesis gravidarum in a previous pregnancy or severe nausea and vomiting. And you should use the two tools, the POC and the HELP score, to know the severity of the condition of nausea and vomiting and the hyperemesis gravidarum. Evaluate the nausea, vomiting, thialism, spitting, weight loss, inability to tolerate food and fluids, effect on quality of life, and the ability to perform daily activity. Also ask about self-reported nutritional status or rapid weight loss. If there is any weight loss in the previous days or weeks, and so on. Ask about comorbidities, which may be complicated by lack of oral intake of essential medications such as epilepsy, diabetes, psychiatric conditions, HIV, hypoadrenalism. Also, you should ask about important surgical history like gastric bypass, band, or sleeve may be the cause of vomiting. The patient had this surgery before. Also, history to exclude other causes like abdominal pain, urinary symptoms, infection, drug history, chronic Helicobacter pylori infection. In examination, you should search for vital signs, temperature, heart rate, tachycardia, occur with dehydration, blood pressure, hypotension, occur with dehydration, respiratory rate, tachypnea, occur with dehydration, oxygen saturation. Also, weight of the patient is important, and muscle circumference. You can measure the weight and you can measure the muscle wasting by upper mid-arm circumference. Abdominal examination, also important. Then look for signs of dehydration like sunken eyes, dry lips, mouth, oliguria, anuria, tachycardia, hypotension. Also signs of malnutrition or rapid weight loss if equal to or more than 5% of pre-pregnancy weight lost. So this is called rapid weight loss if more than 5% of pre-pregnancy weight. Okay? And the muscle wasting, as I said, measured by mid-arm circumference. Also search for neurological signs because it is important. Like what? Like confusion, nystagmus, or ataxia, which could indicate Wernicke encephalopathy, and this is dangerous. Investigation, including urinalysis, nitrites may indicate infection. The presence or absence of ketonuria in pregnancy is not an indicator of dehydration. Midstream urine or clean catch specimen is important if dipstick indicates signs of urinary tract infection. Urea and electrolytes to guide intravenous fluid and electrolyte replacement. Hypokalemia, hyponatremia, chronic kidney disease, high creatinine and urea indicating acute kidney injury due to dehydration. Should do full blood count, searching for infection, anemia, raised hemoglobin and hematocrit, blood glucose level, searching for diabetes, also complication of diabetes like ketoacidosis, ultrasound scan to assess if the baby is viable or not, if there is multiple pregnancy or trophoblastic disease, because symptoms of pregnancy are aggravated with such conditions. In refractory cases or history of previous admission, please check for thyroid function test, liver function test, exclude other liver disease such as hepatitis or gallstones, monitor malnutrition, calcium and phosphate, amylase to exclude pancreatitis, venous blood gas to exclude metabolic disturbance to monitor severity. What about initial clinical assessment? Women with mild nausea, vomiting with pregnancy should be cared for in a community or primary care with antiemetics. So as an outpatient clinic can be managed with oral antiemetic if she is a mild case. Inpatient care should be considered in the following condition: continued nausea and vomiting and inability to keep down oral antiemetics. Also, continued nausea and vomiting associated with clinical dehydration or weight loss, more than 5% of body weight, despite oral antiemetic. Confirmed or suspected comorbidity, such as urinary tract infection or inability to tolerate oral antibiotics. Comorbidities such as epilepsy, diabetes, HIV, hypoadrenalism, or psychiatric disease where symptoms and inability to tolerate oral intake and medication could present further complication. Where inpatient care is required, an ultrasound scan should be scheduled to confirm viability of the baby, and gestational age should be measured and assessed for multiple pregnancy if there is any multiple pregnancy or trophoblastic disease or molar pregnancy, partial or complete molar pregnancy or other gestational trophoblastic disease. Okay, what about therapeutic option? There are safety and efficacy data for the first-line antiemetics such as antihistamine, phenothiazine, and doxylamine plus pyridoxine. And they should be prescribed initially when required. Okay? There is evidence that ondansetron is safe and effective. It's used as a second line antiemetic, shouldn't be discouraged. If first line antiemetic is ineffective, so you can go to the second line treatment like ondansetron. Women can be reassured regarding a very small increase in the absolute risk of orofacial clefting with ondansetron use in the first trimester, which should be balanced with the risks of poorly managed hyperemesis gravidarum. Metoclopramide is safe and effective and can be used alone or in combination with other antiemetics. Because of risk of extrapyramidal effect of metoclopramide should be used as a second line therapy. So it is not first line therapy, it is second line therapy because sometimes extrapyramidal manifestation may happen with metoclopramide, like membrane and whatever. Intravenous doses should be administered slowly, slow bolus injection, slow bolus injection over at least 3 minutes to help to minimize these effects. Women should be asked about previous adverse reaction to antiemetic. If she has a previous side effect for certain antiemetic medication, she should tell you and shouldn't give her this medication if she has a previous side effect. If I know this lady has an extrapyramidal manifestation from metoclopramide, so I am not going to give her. Okay. Normal saline with additional potassium chloride in each bag with administration guided by daily monitoring of electrolytes is the most appropriate intravenous hydration. So normal saline plus potassium chloride in each bag. Guided by what? By monitoring of electrolytes. Combination of different drugs should be used in women who don't respond to single antiemetic. Thiamine, which is vitamin B1 supplementation, either oral 100 milligram TDS or intravenous as a part of vitamin B complex. Sometimes we give vitamin B complex to the patient by injection, for example. Okay, so one of them is thiamine. So I already gave vitamin B1 inside this complex. Okay, should be given to all women admitted with vomiting or severely reduced dietary intake, especially before administration of dextrose or parenteral nutrition. Please remember this. The patient should take thiamine, okay, before administration of dextrose or parenteral nutrition, and in those with reduced dietary intake. All therapeutic measures should have been tried before considering termination of pregnancy. So termination of pregnancy is the last choice if all of the above, all lines of treatment failed, first line, second line, and third line failed, and the complication developed, especially the dangerous complication like variant encephalopathy and so on, so termination of pregnancy may be a solution. So it is the last choice. Okay, I'll summarize here the first line therapy, second line therapy, third line therapy as an antiemetic therapy in case of nausea and vomiting and the hyperemesis gravidarum. First line, doxylamine and pyridoxine, 20 milligram doxylamine, 20 milligram pyridoxine per oral at night. You can add another dose, 10 milligram of each of them in the morning and 10 milligram of each at lunchtime if required. This is in some countries it's called vomit break. This is safe and considered one of the first line treatment. Cyclizine also considered first line treatment, 50 milligram per oral intramuscular or intravenous 8 hourly. Okay, like for example Emitrix is a cyclizine. Okay, prochlorperazine 5 to 10 milligram every 8 hours per oral. Promethazine, chloropromazine, all these, as you see, antihistamine, anti-H1 is considered safe, plus vitamin B6. So I can give doxylamine and pyridoxine or cyclizine or prochlorperazine or promethazine or chloropromazine. Second line treatment including metoclopramide like Brimbrane, domperidone, motilium or motinor, ondansetron like Zofran, All of these are considered second line treatment. So I should start with the first line treatment. If failed, go to second line treatment. But if the patient has extrapyramidal manifestation before with metoclopramide, don't give her this one. Okay? Third line of treatment, hydrocortisone, 100 milligram twice daily intravenous, and once clinical improvement occur, convert to prednisolone, 40 to 50 milligram daily per oral, with the dose gradually tapered by 5 to 10 milligram per week until the lowest maintenance dose that control the symptoms is reached. You know that withdrawal of corticosteroid should be gradually till reach the minimum dose which control the symptoms. Okay? Women taking corticosteroid should have their blood pressure monitored because she is liable for hypertension and screen for diabetes mellitus. Corticosteroid should be reserved for cases where standard therapy have failed. When initiated, they should be prescribed in addition to previously started effective antiemetic. So in combination with another antiemetic, you will give the hydrocortisone. So this is considered a third line therapy. Okay? This is the end of my lecture. I hope it was clear enough. This is my box published on Amazon. This is the link. I'll put in a comment. This is my link on YouTube where you can find this lecture and also another lecture before about nausea and vomiting in pregnancy. But in this lecture, I depend on the updated guidelines in 2024. So you can see post lecture, especially the last updated one. Okay, this is another scientific blog spot. Scientific side belongs to me. I hope this lecture was clear enough. Thank you, everybody. All the best.